Welcome, everyone. Thank you for joining our Clinical View series on thriving as a flexible health system. I'm Matt Smith of GE Healthcare. During our last two sessions, we focused on health systems revisiting the role of acuity adaptable models of care and what's critical for succeeding in such a model. Today, I'll be talking about the acuity adaptable model with Dr. John J. Gallagher, professor and clinical nurse specialist at the Francis Payne Bolton School of Nursing at Case Western Reserve University and a former executive member of the American Association of Critical Care Nurses, or AACN. So, Dr. Gallagher, before we jump into acuity adaptable care, can you first share a little bit more about your background and your experience in healthcare?
Absolutely. So currently, as you noted, I am a professor in the School of Nursing at Francis Payne Bolton. But before that, I spent 36 years as a nurse and clinical nurse specialist in trauma and critical care, and also ran the trauma program at Penn Medicine and had the opportunity to work with design of units and also running programs at the executive level, as well as teach and provide clinical care.
Oh, terrific. You certainly have a wealth of experience to draw from. So, thinking back on your long career and on your career experiences, where would you say acuity adaptable care has made the most considerable impact?
So I think in a couple of areas, when we were looking at designing new space, not only at the trauma center, but as a new pavilion for Penn Medicine, one of the things that we looked at was the ability to have an adaptable unit. And most recently at their new pavilion, where they developed the rooms so that they could be used and configured and kind of have a patient be cared for in one area over the kind of their care journey. Before that, when we were developing the trauma center, we were looking at the ICUs. We started to look at, how could we make this a space not only where the patient could be cared for and be comfortable, but the family could be part of that as well. And there had been some opportunities to on certain units that were built, and they were all built similarly, all the ICUs, where you could have an ICU bed and then other areas were kind of tailored a little bit more to med surge. So I've seen it develop. And then in addition to that, during the COVID pandemic, we also had to expand into areas and make those adaptable areas more in a crisis surge mode, not necessarily in a thoughtful, planned way, but we were able to see how that might be done if we had to surge and kind of expand our space.
So, when we discuss acuity adaptable care, we often talk about potential impacts on quality. Overall, what have you seen in these AAU models, and specifically that impact on patients?
So some of my experiences, not only from my own personal experience, but in having talked to others, and the experiences that I've seen and the information that I've gotten is that when you have these adaptable units, it's not only great for the patient and the family because they get to stay in one space and they get to know their caregivers. But also, there's a lot of benefits specifically to the hospital itself in that we reduce handoffs, we reduce the chances that patients are going to get infections, we reduce staff injuries from moving. All of those things are potential problems that we see. And so in speaking to those, as well as my own observations, it's just more seamless having an adaptable unit where the patient doesn't have to move.
So, Dr. Gallagher, we know that part of the intended benefit of acuity adaptable care is the impact on the clinical staff, and in particular, nurses. Overall, how do you think nurses are impacted?
So I think some of the things I mentioned in the previous answer, in that they have that consistency of care with their patients. So we don't have to hand off a patient because they go from one level of care to another, meaning that they still have that relationship with the patient and the family. They also don't have to move the patient themselves, and often there's the report off, and all of that can take a period of time. There's a disruption in workflow when they have to move a patient. These are some of the things. But the other piece of it is that it does require a different way of thinking in the way you're caring for the patient, because you're going to have them from one level of care to the other. So it almost requires a mental model of thinking about how you're doing care differently. And it also requires that the staffing be appropriate and the level of uh, staffing, the level of experience of the nurse, be able to take that patient from one area to the next. One of the examples I often give is that, if you're in a critical care type unit and you're going to go to a step down level of care, sometimes the number of patients that the nurse will care for from a ratio standpoint will go up. But if you're in critical care and you're used to caring for 1 to 2 patients, and you're on a unit that now you're going to care for that patient for an extended next level of care, then that has to be something that's acceptable and you understand the concept behind it. And it's the mental model that everybody, a shared vision that everybody has for that patient, and the benefits not only for the patient, but also for the family and also for the providers caring for the patient as well.
So I think that's a great overview on some of the challenges related to the impact on the nurses. What are some of the other challenges or roadblocks that hospitals should kind of keep top of mind when transitioning to an acuity adaptable model?
So there's a number of things that I think are important, and the first is as I said it, the shared mental model that everyone has, that it has to be shared by the providers, by the nurses, by administration, and that everyone is coming from the same place and realizing the benefit, but also understanding what those challenges will be. There's the space issue. Not all units lend themselves well to this because of the way they're constructed, and so having a unit that is one that will allow for that adaptability. For instance, if you have a unit that doesn't have a lot of space in the room, it's very hard to flex up and down if the patient requires additional care and equipment. So the unit design is something that's important to look at. The model of staffing is a bit different, and I think I alluded to that with nursing. But I think that one of the challenges that we don't often think about is what type of monitoring equipment are we going to use? Uh, Often when we're in the ICU, a patient is tethered to a monitor, and as they move out, they tend to be on more like a telemetry unit that allows less monitoring parameters, but is a little bit more flexible. So, what type of equipment, what type of monitors might they need to consider as they decide to go to this? And I think I mentioned before about the staffing model, and then also what's the staffing mix and the capability of the nursing staff. We moved often from critical care, and we think about the total care model where the nurse does everything for the patient, to more of a team model where we have different levels of provider that are assisting or helping the RN who may have more patients but would be doing less physical care. So these are all considerations. And again, thinking about this from the beginning, and perhaps even thinking about, do we do this on one unit as we're either reconfiguring or redesigning a unit and use that as a model unit? And do we focus on one population that might work?
Great, great. So we talked a little bit about the physicality of the space, and I know you mentioned a little bit about the technology involved with bedside monitors, but what are your thoughts on some other tools and resources that can be used to support this team? Are there any other technologies that you think are kind of super critical to this endeavor?
Yeah, I think interoperability of monitoring systems and the technology that can give us the data and kind of harness it from different tools. So often data can come from a monitor and then it goes to the electronic health record. But the question is as a clinician, instead of having pieces of data, are there tools, electronic and data management wise, that allow us to take all this information and be able to provide it in a usable form to the clinician? And then when we think about, for the patient who's being monitored, let's say a wearable where they have different types of parameters that are being monitored, heart rate, respiratory rate, pulse oximetry, when those things are coming together, how do we know, and what are the patterns that we see that might tell us the patient's in trouble? And then how's that getting pushed out to the clinician? Because at the very basic level, we know that there's paging systems that people are notified when there's a violation of heart rate. But it's not just about giving somebody a bunch of information, but how do you give it to them in a usable package so that they can see it, not just dumping it to the health record where they then have to go look for it, but then in a way that will help us see if a patient needs intervention sooner than later, and then doing it in a way that you're not giving them a lot of information that's not helpful. We talk about inactionable alarms, or some would call them nuisance alarms, where the staff is notified, but often erroneously so. So, that also has to be part of it, because if it becomes burdensome to be interrupted with information that's not useful, it kind of disrupts workflow and kind of pulls the clinician's attention away from the patient.
So I can imagine that this shift to acuity adaptable care can seem incredibly daunting to hospital leaders and to staff. Are there any smaller ways, incremental steps, focus areas that you think organizations can really hone in on to start making this transition?
Yes, I think I kind of mentioned this a little bit, but when you're starting this, I think it's good to, even if you're designing a whole hospital and you plan to, that's ideal, because not always can somebody say, I'm getting a chance to start from the ground up and I'm going to build my whole institution this way. But perhaps as they look at new designs of floors, thinking about doing it on a unit, or using a unit that may be optimally designed, that has enough room to flex up and flex down, to have that unit be a pilot unit, and making sure that all of the stakeholders who would be involved in that, from the medical directors, the unit leadership, hospital administrators overseeing it, down to uh, environmental services, making sure that the bedside nurse, not just the leadership, are involved in this process and design. I get back to that single shared mental model of, this is what acuity adaptability is, before that people understand that before you go designing a unit. Because if you're going to do that, um, you need to have that as your base before you go designing a unit. You can design a unit. We saw that happen during COVID, where we expanded units and flexed things up, but they didn't necessarily work for everyone, because they didn't understand or weren't familiar with how that unit would be utilized. So I think those are uh, starts. I also think perhaps, if you're looking at new technology, think about technology that can flex up and down, and working with the vendors and find out what do they have available and what can they offer that allows that flexibility, and start thinking about that even if you're not changing your physical space.
So that kind of leads us to the next question of, taking a step back and really looking at this from kind of a macro level. What do you consider, or when you consider the future of healthcare, what role do you think that these acuity adaptable models could and should play? Um, and how do you see that changing in the coming years?
Well, one of the things, it's not a secret that after the pandemic, we had many health institutions that had financial issues, because some of the care that they provided and some of the patients they took care of weren't necessarily there during the pandemic. This had a downstream effect on their revenue, and um, we know that a lot of health systems were struggling. One of the things that happens is, when you have these patients in, let's say, not during the pandemic, but now they're in your emergency department, or they're in places where we we back up the emergency department, or we back up other areas, because the units where they would normally go don't have a bed. Um, when you have that level of flexibility, where you have an adaptable unit where you can send a patient to different areas and perhaps flex up and flex down, that makes it a little easier to place them. And thinking about the models that are now different, as we have shortages in nursing staff, and as we think about, how are we going to change the way we provide care. um, we talk about ratios, and the fact that, yes, you can flex that up and down depending on what the patient needs, but uh, how will the model change? Can we change our model that will account for taking that patient from higher acuity to lower acuity and back up should they need it? And how do we do that? It is requires a different way of thinking. It requires a different way of thinking from hospital administration down. but what are the things that we can do, and how can we do that so that we're not kind of pigeonholed into the way we did things in the past, where patients are only going to one type of unit. Now the patient has to move from one unit to another, and now we have to wait for a bed to become available on that unit in order for that to happen. Meanwhile, the system backs up.
Well, that's going to bring us to a close today. Dr. Gallagher, thank you so much for your time and for sharing your observations and insights with us on acuity adaptable care models. It's been great to hear about your experiences, and I'm sure other hospital leaders will find your insights valuable as they listen and consider how their organizations will approach acuity adaptable care. And again, thank you to all our viewers for joining us today. So we'll see you next time. Thanks.